Violet was another interesting client I had. And this is, I'm giving you some, this is, a lot of these people are from the state hospital, and this is about differential diagnosis between autism and some kind of psychotic condition. And Violet was another one that I had over the years, and again had a dual diagnosis, autism and schizophrenia. They weren't quite sure with her, and it depended on what the predilection of the clinician that was attending to her was. And like all my clients I had in the hospital, I went over their records very, very carefully, especially ones that seemed to be in a lot of discomfort or pain. And she was one of these people. She sat in a wheelchair all day and gripped the sides, and literally a white knuckle grip, like just as hard as you can make your fist, and just sat there all day screaming like, ah, at the top of her lungs. Unlike Joe, she was not violent. She was a very slight woman, 28 years old roughly around, and weighed, 100 pounds soaking wet, about 5 feet tall, very small woman. And didn't seem to have any feeling or ability to move her legs. We didn't see anything. Joe could a little bit. He could still get a little bit of movement, a little bit of feeling. She did not, and we didn't know why she was impaired, why her legs were impaired. That was not evident anywhere in her chart how she became that way. And that's something you often see in the mental hospital, and you could often suspect, at least back in the day, that probably she was the victim of some sort of violence by another client, another patient. And especially if it wasn't really well documented, put in a chart, sometimes that's just kind of a, thing. But that happened long before I had known her. She had very striking looking, bright red hair, really bright red hair. And just screamed at the top of her lungs all day, like in what seemed like agony. But people didn't think that she was in pain. They'd give her painkillers and she would still scream. And so we weren't quite sure what that was about. She would every once in a while, like Joe, burst out laughing and smiling, and then after a few minutes she would start screaming again. So, like Joe, we first thought maybe, demonic possession was a possibility. Then we decided to become more scientific about it and look into what's going on. Of course, she was nonverbal, so she couldn't tell us whether she was hallucinating. But again, like Joe, she would look off at the distance and start smiling like she was seeing something or hearing something every now and then. So we didn't know with her, right? Didn't know. We had another patient who had this, I think I mentioned to you, phenylketonuria. The inability to process phenylalanine, the amino acid phenylalanine. And he would sometimes scream and do this thing all day, but in his case, there probably was a real physical discomfort or pain going on. We had her checked for that, and she did not have phenylketonuria. And so we weren't sure about a physical cause of pain, or I couldn't really see anything that was a physical cause of the pain. I looked into her record, and I found something that was very interesting, and that was that both of her parents had been physicians. And when she was born at the hospital, this is back in the day, the attending physician thought, oh, this is a baby of a fellow physician, so what we're going to do is we're going to give this baby extra special treatment. So what they did is they gave her extra oxygen at birth. And this is something that we now know it can cause a couple problems. One is it can impair vision, it can cause problems with the optic nerve. The optic nerve is still developing, I think, and so extra oxygen can cause a problem with that. And there's some, at least older research that suggests that this also can, the same nerves involved can also be damaged, also one that might be related to autism. And so this was a clue that she might be autistic rather than schizophrenic. And so because of that, what we did is, Francesco's the next one. That's a typo there. I don't know how that got on that. So what we did with her is, rather than try her out like on Joe, try her on some antipsychotic meds, instead we tried her on a new drug that was brand new at the time, which was Zoloft. I'm dating myself here. And so we put her on Zoloft, Zoloft takes about 6 weeks to really kick in. And sure enough, And there was some evidence at the time, I don't know if this is really borne out in the modern era, but there was some evidence at the time that some people with autism, that SSRIs would improve their condition. Not everybody, but some people. And indeed, in her condition, her situation, after about 6-7 weeks, she improved dramatically. And she also, the agitation calmed down. She could just be very mellow out in the room. She stopped screaming all day. Seemingly seemed like she was happier, and we were really happy with it. Because before, the only medication she was getting was chloral hydrate, which is a tranquilizer. She was getting a PRN, which is as needed, which was quite a lot. And we were concerned that she was getting this, the nurses at night, would she be screaming? They didn't know what to do, so they give her this PRN stuff, which is not a good thing to be taking sort of long term. And she did very well on Zoloft. And that was also another case that was resolved very well. But in this case, really we thought not psychotic, probably autistic, because if she had been psychotic, probably the Zoloft wouldn't have done much for her. So that was an interesting case that I had. And again, it goes to the idea that when if you work in an institution like this, it really pays to go through the records thoroughly and look back, almost like an archaeological expedition. In some places in the state hospital, some of these people, like Joe, had charts that were, like from here to the ceiling, from his 30 odd years of being in the hospital, and those had been stuck in a warehouse somewhere, and you had to go and get them and retrieve them and stuff. And nothing was digitized back in those days, and so you had to go and find these records. It was very helpful to do these sort of deep dives into the history of these people. And I was really quite surprised to find that nobody else was doing this. Maybe one other psychologist would do this kind of thing. Nobody else was doing it. Again, being a behavioral institution, we were sort of forced to practice behaviorism. In the behavioral sense of things, you don't care really about the past stuff, the way past. You just care what is sort of the immediate precursor to behavior, and that's what you're really trying to hunt out and find. Her case did nothing. All the behaviors in the world, there was something internal going on. And so I found looking up in the charts was very helpful. So just something to think about if you find yourself working in an institution somewhere. Giving you all my success stories here, none of the, but by success I mean that she was not cured, she was just no longer in agony, right? And again, at the mental hospital, that is what, many times, that's what you count as success. And again, I just put this up again, just to remind you of this, that there's a shared genetic contribution between autism and schizophrenia, and there's some overlap of some of the symptoms, especially the cognitive, social withdrawal things, and sensory overload kinds of things here. And then there's some things that are a little bit separate. Just something to think about. Okay, another case study. I might as well give you two. This is another one that was really interesting, and this was a guy who was, we'll call him Francisco, and he was a 27-year-old high school graduate. His family had come from Mexico when he was really small, a baby. They'd come from the Oaxaca region, and the parents primarily spoke Zapotec, which is an indigenous language, and Spanish was their second language. And Francisco was basically raised in the United States. His English was perfect, and he spoke a little Zapotec, and he spoke no Spanish, which is very interesting. Which actually, if you think about it, was actually a little problematic for him, because people would expect him to speak Spanish and would speak Spanish to him, and he would not really understand it or didn't want to understand it. And that caused him that was a kind of a stressor for him. The language situation was kind of a stressor. He was admitted, he was, by the time I saw him, he was in his 20s, late 20s, but he'd been admitted to the mental hospital after having numerous violent confrontations, both at school and on the street. And he was diagnosed as paranoid schizophrenic, and he was on a low dose of an antipsychotic. I think he probably was on Thorazine, probably got a low dose of Thorazine every day. Mostly kept it together. Mostly was fairly together person. Did not report having any auditory or visual hallucinations that we know of. So at least But again, with somebody paranoid, you never know, because they just might not want to tell you about it. Okay? And he did sometimes seem like he was hearing something or seeing something, but again, when we'd ask him about it, he would deny this. And if you pressed him, he would start to get stressed out. And when he started to get stressed out, he would become agitated. And eventually, if he became agitated, he would start to sort of self-reinforce the agitation and work himself up. And then he would break out in violence, and he'd just run around and hit people. And then he'd have to be tackled and, give him a big shot of Thorazine in the butt or something. Which only happened a few times when I worked with him. It did happen a couple times when I worked with him. So one thing we did when we started to work with him was to start to help him with, when he started to become stressed about things. And we'd help him sort of de-stress, we'd help him de-escalate. And that was kind of our working paradigm with him. And he was somebody you could sort of talk to, and he was very coherent and very together guy. And sometimes you could just sort of de-stress him out, take a deep breath, and he would respond and he'd be fine. And so we also tried to keep the stress levels at a minimum. We didn't make him do stuff that he would find stressful. And there's all sorts of various things. This was in the locked-in facility I worked in Santa Cruz. There was activities during the day, things like that. And some of the things he liked to do, and other things he really did not like, and we just wouldn't make him do those things. And that seemed to help him quite a bit. After working with him for a while, I could kind of sense when he was getting stressed, he would start to work himself up. And I found that was a really good thing to do to de-escalate this was to distract him. And the interesting thing about him that was really fascinating was that he was a film buff, one of these film guys. Literally had an eidetic memory for films. And he could tell you who was in the film, who produced it. He could recite dialogue from like hundreds and hundreds of films. He knew it was actually pretty incredible. It was almost like an idiot savant level of knowledge about films. So what I would do is, when he would start to become stressed and start working himself up, I'd ask him about a movie. I'd say something, what's your favorite, film noir movie? And he would go, this movie, from back in 1940, blah, blah, and he'd go off. And he would start to go off on that, and that made him very happy to talk about that. And he would forget about becoming stressed and paranoid about things. So that was an interesting kind of way to work with him. And he could talk for hours. And I also had to learn to not, I couldn't sit there for an hour and listen to him. I had to learn to sort of gently say, I really got to go back to work now. What you're saying is fascinating. It's really interesting. You know so much. And then kind of ease out of the conversation. I got very good at that too, because you don't want to abruptly leave, because then you get stressed again, right? But he was an interesting guy that I worked with for about 2 years. And probably was going to be, he was a guy, I think, with the right support. He was a guy, I would say, actually would have benefited from psychotherapy. One of the reasons I wanted to include him, to talk about him, he was a patient I thought actually would have benefited from psychotherapy of some kind. Because he was very articulate, he was very smart, he had these paranoid ideations, but they weren't overwhelming him all the time. And he's somebody I think would have actually really benefited from it. Unfortunately, he came from a very poor family. Probably, was one of these guys who went in and out of the hospital. He was there for about 2 years when I worked with him. He didn't go in and out, but my guess is he was high enough functioning that at some point they would have, kicked him out on the street, and he would have stopped taking his meds, and then he would have started being paranoid again and got violent. They would have brought him back in. So he's one of these kind of revolving door guys. But he's somebody I think some kind of intervention could have helped him. Either psychosocial, educational, something. I think he would have been very good.